So our speaker today is Dr. Ubaid Seedat. He's currently our fellow in pulmonology, and we're obviously very lucky to have him. We're going to be discussing interstitial lung disease, which I think everybody takes for granted, and I might chat about a couple of cases we're not done, just because these things get missed. And they often present very late and they have quite a devastating consequence. Because of that, so I think we're looking forward to hearing what you're going to say.
Thank you.
Thank you.
Good day, everyone. It's a pleasure to be at this forum. Today, I'm basically talking about interstitial lung disease 2024, some basic principles and some new insights. So disclosures, I currently have none. The keywords used in this topic we're going to talk about is ILD, so interstitial lung disease, DPLD or diffuse parenchymal lung disease, IPF, idiopathic pulmonary fibrosis, PPF, progressive pulmonary fibrosis. I'm sure all of you can figure the last one out. Just so some background, ILD is often referred to as DPLD. Like many umbrella terms in pulmonology, it generally represents quite a heterogeneous entity. It's grouped together as the collection of diseases share clinical, radiographic, and pathological features. And it's quite a heterogeneous disease, and the heterogeneous nature cannot be more emphasized as wide variations are seen. The variations are seen in clinical presentation, clinical course, and therapeutic algorithms we will break down during this talk. So one might be wondering, is ILD technically a misnomer? Technically, yes. By definition, the interstitium of the lung actually refers to the supportive tissue framework of the lungs. This includes the alveolar epithelium, capillary endothelium, basement membrane, and associated lymphatic tissues. Diffuse parenchymal lung disease actually more represents the umbrella term, as certain diseases may have a predilection for the alveolar itself, such as pulmonary alveolar proteinosis and organizing pneumonia, while others may actually target small airways like respiratory bronchiolitis. But generally, for medical nomenclature, the terms are interchangeable. So just some historical background, which I always think is important. So the late 19th and early 20th centuries brought forth some early concepts of pulmonary fibrosis. So in 1872, a German physician by the name of Van Boel used to use specific terms to actually describe post-mortem cases, and it involves the excess of connective tissue in the lung is what he described. Later, Dr. Hammond and Rich actually coined the term interstitial pulmonary fibrosis, and for you guys so known and familiar with the term, actually acute interstitial pneumonitis has been renamed as Hammond-Rich syndrome, interestingly. In terms of the modern day classifications, it initially started in the 40s and 60s with pathology. Oswald and Parkinson actually described the term honeycombing of the lung, and Liebau and Carrington actually described UIP. However, they actually termed it cryptogenic fibrosing alveolitis. Significant advancements in radiology in the past 30 years has actually led to our recent guidelines, the ATS, ETS, and Relational Society providing multiple statements and a glossary of terms, and this has led to our modern day classification. That's just a picture of honeycombing. That's the classical description of cystic airspace. So modern day classifications are actually quite complex. This is actually a classification put in the journal Nature. And there's a lot going on here, but we'll try and break it down in a bit more simply in the next slide. And this is how the ERS breaks it down. Very similar, but again, quite a lot to take in. Interesting enough, simply put, a simplified definition is it's a heterogeneous and complex group of diseases affecting the lungs, with the hallmarks of disease being inflammation, fibrosis, or a combination of the two. And this is just a simplified diagram explaining the basic principles of inflammation and fibrosis, but we will go into the pathophysiology in a bit more detail later. So a simplified classification or a simple way to approach ILD is this. Number one, is the etiology known? And when we talk about a known etiology, I'm just trying to answer. We talk about organic exposures. And organic, by definition, means they have carbon-hydrogen bonds, animals, molds, etc. And this leads to an entity called hypersensitive pneumonitis, which again is a very diverse ILD in itself, and it typically represents a dysregulated immunological reaction to inhaled antigens. Then we can talk about inorganic exposures. Those of you are familiar with the concept of occupational lung disease. We can talk about smoking-related ILD. Three hallmark ones are actually desquamated interstitial pneumonia, respiratory bronchiolitis with ILD, and Langerhans cell histiocytosis. And then we can have drug-induced ILD. The 4 big classes I want you guys to all be familiar with is our antiarrhythmics, antineoplastics, antibiotics, and immunomodulatory drugs. And then connective tissue disease, which I'm sure we're all familiar with our big classification of connective tissue diseases. Please forgive me. RA, scleroderma, SLE, inflammatory idiopathic myopathies, and the more recent entity called IPAF, which is interstitial pneumonia with autoimmune features. In terms of continuing this classification, is the etiology unknown? We talk about granulomatous disease, typically seen with sarcoid, and rare forms of disease called LAM, which I'm not going to read it out fully, vasculitis, and PPFE, which is another very rare form of ILD. And then we talk about an interesting group called idiopathic pneumonias. And this is broken down into IPF and non-IPF. And the important thing here is they do represent a primary pulmonary disease and they don't have a secondary systemic disorder. So just some pathophysiology of fibrosis. That's just a very dysregulated myofibroblast. It always starts with an agent of initiation. Whether it's a primary disease or an unknown, that's the initial agent of damage and initiation of this inflammatory or fibrotic response. Then there's a genetic predisposition, the important role of the telomere, which we'll get to a bit later, and there's familial variants with the 2 big genes being the TERK and TERT gene, and these provide a susceptibility to developing this dysregulated response. And then the key dysregulated response is mediated by cytokines, and the hallmark cell actually being the myofibroblast, which leads both to aberrant connective tissue and vascular remodeling. And that's just basically a very nice diagram in the ELS going through the basic epithelial and endothelial damage, this abnormal fibroblastic interaction, and this aberrant repair and fibrosis leading to this dysregulated and quite abnormal architecture of the lung. Moving on, we're going to talk about the burden of disease. There's numerous studies available, but in general, they are geographically limited. The other important point is due to the heterogeneous nature of the disease, it's difficult to basically give exact statistics. But IPF, which is part of your IIPs, is generally well documented, around 14 to 28 per 100,000 in the States, similar numbers observed in Europe. But again, there are a lot of studies I could quote you to in the Lancet, the BMJ. Locally, it was claimed in an editorial a few years ago that there is a paucity of data in our local Southern African setting. However, there is some good local data emerging in our circuit over the past few years. And that's just some key studies basically pointing towards that. In terms of early diagnosis and evaluation, I cannot emphasize why it is important. In general, ILD by itself, or when it's a manifestation of a primary disease, is a key driver and an independent marker of morbidity and mortality. And early recognition can lead to early identification and therapeutics. This can lead to the monitoring of the therapeutics, and even in the future, it can help guide access to clinical trials. It actually starts from the primary healthcare setting right up until the pulmonologist. And again, it's often a progressive and debilitating disease, so early recognition is essential. There was a recent editorial in Nature actually highlighting how often it's misdiagnosed, as a large proportion of these patients were actually diagnosed with obstructive airways disease. Just the key pointers and takeaways is clinical suspicion is important. A lack of awareness implies a lack of recognition, and a lack of access to radiology and spirometry, which is important in our setting, can also lead to a limited diagnosis, just to keep aware of. Oh, my apologies. This is just a basic overview of how we will approach a workup with a patient of ILD, but we will go into a lot more detail now. So where do we start? I think bedside clinical suspicion should never actually be forgotten. It starts in the history, and demographics is key. Certain ILDs have a predilection for certain age groups. Younger females always suspect and consider connective tissue disease. When patients are above the age of 60, male predominant, consider your IPF. And also look for your cardinal respiratory symptoms. They generally are chronic and non-specific. Cough appears to be the most prevalent, between 50 and 90% actually reporting it as their index symptom. It may actually precede any associated radiological changes. And then dyspnea and fatigue are commonplace in these patients. They may have an acute presentation, otherwise due to an acute exacerbation of their ILD, or they can be an infective precipitant. In terms of systemic symptoms, this is key because it may guide you towards an underlying disorder. Look for symptoms of the eyes, skin, joint, and even vasculopathies, as they may point you toward the diagnosis of sarcoid or even certain connective tissue disease. The next is to do an exposure history. This, while might seem simple, is actually extremely complex. A smoking history is not just a yes or no, and there's even some good evidence to say it's not even about pack years, as there's a lot of recency bias when patients report the amount of cigarettes they smoke. Medication history is also quite important. Obviously, like I mentioned, antiarrhythmics, antibiotics, immunosuppressants, and chemotherapeutics. And it's important to ascertain the occupational history. We talk about vocational and avocational exposures. And while it might seem simple, it's really not. During my reading, there's over 200 exposures which can lead to pulmonary disease. And I found two useful websites, pneumotox.com and HP Lung, which may help guide you. But again, comprehensive history is key. In terms of our exam findings, it's never to be overlooked despite modern day advances. Number one, we want to look for clinical indicators of ILD. So clubbing is something we taught a lot about. The studies actually describe prevalence of between 7 and 52% with no obvious correlation to severity. The mechanism is obviously multifactorial and not fully elucidated. We talk about abnormal pulmonary circulature, the role of the circulating megakaryocyte, and it's usually mediated by growth factors and possibly a genetic component. In terms of the respiratory exam, only with truly advanced disease do you might see a decrease in chest expansion. But something that's very important in auscultation is the presence of adventitious sounds, classically described as non-musical and discontinuous. Pulmonologists like getting excited when describing Velcro crackles, heard mid to late inspiration, not affected by cough, and higher in pitch than coarse crackles. While at first it may seem just simply fun to hear, it's a little bit more than that, as its presence actually strongly correlates towards fibrosis, and it may actually be used in screening. There's some early studies that crackles can actually be picked up before the disease overtly presents, and it's actually present in about 60 to 93% of patients. Thus, an important thing of cough, clubbing, and crackles, it does remain an important pickup tool despite modern advances. Moving on, we want to look for number 2, clinical features of an underlying disorder. Obviously, guided by your history. Look for features of smoking, whether it's odor, skin and mucosal discoloration. Look for drug exposures. If the patient has atrial fibrillation, are they on amiodarone? Do they have skin side effects of amiodarone? If they had recurrent UTIs, are they on macrodentin? Do they have a known connective tissue disease or malignancy, and on specific drug therapies that may actually cause ILD? And obviously look for features of connective tissue disease and vasculitis, whether it's a rash, Raynaud's phenomenon, skin and musculoskeletal abnormalities, and obviously organ involvement beyond the lung. And then features of sarcoid, I'm sure we're all familiar with. The classical involvement is the eye, the skin, and the nose. And then rare things, patient with tuberous sclerosis, always consider the patient having LAM as an etiology. Just some simple pictures describing discoloration and nicotine staining on the hands. And next, we want to look for clinical indicators of complications. The hallmark complication really being hypoxia and its associated sequelae, whether it's the presence of cyanosis or polycythemia. Its prevalence is actually difficult to ascertain. There's no good studies highlighting how prevalent it is. And then also you can look for features of pulmonary hypertension and pulmonary, with some key clinical features, the patient having right heart failure, elevated JVP with some characteristic waveforms, presence of a parasternal heave and a loud second heart sound. The prevalence generally varies. Small studies describing how much is prevalent. It appears to be prevalent between 7 and 48%, but this was picked up on indirect screening with a transthoracic echo. Another important thing, especially in our elderly patients, or patients above 60, which are not that elderly anymore, we must always look at associated comorbidities. Comorbidities are quite common in IPF. It's important to look for GORD, which we'll touch about, PH, associated cardiac disease, obstructive sleep apnea, and there is quite a strong prevalence of depression in these patients. The next is we need to diagnose these patients. Imaging is critical. We always start with an X-ray. I like an analogy, call it humble, but still useful. We always adhere to our fundamentals in terms of assessing the quality of the X-ray and going through our basic evaluation, whatever system we may use. The radiological concept of ILD actually well put is it's a disease of infiltrative opacification of the lung, but there's great variation due to the wide spectrum of disease in ILD by itself. We really talk about a reticular interstitial pattern is the classical descriptor. But again, there's a large amount of variation depending on the underlying disease, especially when we consider patients like sarcoid who have quite an extensive presentation. The important thing is when we see fibrosis or involvement of the lung, is where's the location? In pulmonology, we like talking about upper lobe predominant disease, especially with your Langerhans cell, HP, sarcoid, and our pneumoconiosis, and our lower lobe predominant disease, such as our connective tissue disease, our IIPs, our drug-induced, and our AIPs. And I'm sure you'll hear all the pulmonologists get very excited and talk about an apical basal gradient. Again, an X-ray is not sufficient for a diagnosis, but it's important to rule out mimics. A lot of pulmonology textbooks actually well describe how acute heart failure can mimic ILD, and it's important to look for other features of infective etiologies. And again, changes can actually be seen quite early on X-ray, and this was a nice study I found basically highlighting a patient actually had reticular infiltrates prior to symptoms and how it evolved with the patient's presentation. HRCT, or high-resolution computed tomography, remains the imaging of choice. It usually utilizes cuts less than 1.5 millimeter, and it's important to assess the lung parenchyma. No contrast is required. I'm sure the nephrologists are happy. Time to scan is quite short, and the radiation dose is about 3 to 7 millisieverts, which is about half for CT abdomen. Inspiratory and expiratory imaging occurs. There are also certain ways you may position the patient, but that is quite nuanced. But the inspiratory and expiratory imaging typically is important to detect air trapping. In terms of an assessment, it's, apologies, not quite simple, and it's good to have a general approach. It's important to assess basic architecture of the lungs and airways, pathological changes, and where the distributions of these patterns are. And it's usually not good to do in isolation, but with a trained multidisciplinary team from a host of specialities. There are multiple guidelines available, and actually the Fleshless Society actually provides about a 48-page glossary of terms used to describe a lot of our findings. In terms of our basic pattern, we talk about linear, reticular pattern, nodules, ground glass, crazy paving, consolidation. If present, it's important to see where the burden of disease is, or what is the burden of disease, and where it's distributed. So there's actually a whole textbook on this. And interestingly, when we see nodules, where is it present? Is it perilymphatic, usually strongly associated with sarcoid? If we see ground glass opacification, what is that associated with? If we see a reticular pattern, what is the burden? Where do we see it? If we see consolidation, it's important to note if there's air bronchograms. And if there's a cystic pattern, where are the cysts? Importantly, are the cysts associated with nodules? Quite important for more nuanced diseases like LIP. The next one is mosaic diffusion. That is technically wrong. It should be mosaic attenuation. You can only truly label it mosaic diffusion once you ascertain it secondary to a vascular pathology. Moving on, pulmonary function testing. Very important. It's key in diagnostic purposes, prognostication, and therapeutic guidance. The initial use of antifibrotics is actually guided by a low FVC. But we have some good local data and guidelines available, which was published about a year or so ago in the South African Journal of Thoracic Medicine, and basically just going a simplified way. Always start with your quality assurance. Can the patient blow out for 6 seconds? Are we able to produce reproducible criteria? And then we start with our basic reference values. We always go back to this, as keeping it simple leads to some foolproof methods, as mistakes are can easily be made in quite a difficult diagnosis. When we have a restrictive pattern, it's always good to do plethysmography to ascertain our lung volumes. It's important to note that different types of ILD may have significant variation in how they might manifest. Certain disorders, including sarcoid or small airways disease, may actually manifest with obstructive spirometry. But generally, it's used in conjunction with other modalities. We often seek a restrictive pattern. We talk about a low FVC, a low total lung capacity, a low DLCO, or transfer coefficient, and a low KCO. For those wondering, KCO is basically a DLCO over your alveolar volume. So the importance and utilities of PFTs are also better appreciated when viewed under specific etiologies. In ILD, we talk about the hallmark, like I mentioned, of a low TLC and DLCO, but it's important to note that worse values with steeper declines correlate with an increase in mortality. And they can also guide and allow for monitoring of therapeutics. In connective tissue disease, these principles are basically shared. And it's also, again, just to mention, it's not in isolation, but with other clinical indicators. Just out of interest, its utility can also be used in scleroderma with the DETECT algorithm, as you can work out a FVC over DLCL ratio. And a ratio of more than 1.6 may actually point to pulmonary arterial hypertension. The next step is serology. Again, it can seem quite broad. We try and avoid a blanket testing for all patients, and rather the guidelines do suggest it be on a case-by-case basis, and it's guided by history, exam, and radiological findings. Obviously, the importance of autoantibodies are critical in connective tissue disease, as per our EULA ACR guidelines, and they may be helpful in a previously uncharacterized disease that emerged called IPAP, which some might argue is man-made, but it can help provide some therapeutic and diagnostic purposes. It may also be present with an absence of clinical features. There was one study basically showing that 30% of patients with IPF may actually have a positive ANA, but they do not meet criteria for a connective tissue disease. Importantly, another important test is the ACE level, which is typically we test in sarcoidosis. It's often elevated. There are many causes of raised ACE, importantly in our South African setting being TB. They may correlate with activity, but it's supportive rather than specific, and there's actually a whole host of polymorphisms in the ACE gene that may actually decrease its sensitivity and specificity as described. There's also the role of antigen testing in HP. This is actually markedly complex. It's not easy as an abundance of etiologies. It's useful if negative, but it should be guided by exposures. Interestingly, diagnosing HP without identifying an antigen actually correlates with adverse outcomes. Some centers actually use inhalational antigen testing, but this actually requires expert centers and interpretation. The next thing I'd like to talk about is bronchial alveolar lavage, which we don't practice at all centers, but is helpful in helping to diagnose ILDs. Bronchial washings may actually give you a specific cellular pattern which can guide you towards a certain diagnosis. We do practice some of these things, especially with milky fluid being the hallmark of pulmonary alveolar proteinosis, and bloody aliquots typically associating towards diffuse alveolar hemorrhage. But certain lymphocytic and even CD4, CD8 profiles may help point towards a diagnosis of sarcoid or hypersensitivity pneumonitis. So let's say we've done all of that and we still don't have a diagnosis, which is quite common. Around 5 to 10% of patients will still not have a diagnosis, despite the involvement of rheumatology, radiology, etc. The next step is essentially to get tissue. Why is it important to get tissue? It can aid in prognostication and therapeutics. So what options do we have for us getting tissue or invasive tissue? Number one is a transbronchial biopsy. The next step is a transbronchial cryobiopsy. And then the last option is technically a surgical lung biopsy. Generally, the more invasive, generally has a higher tissue yield at the expense of complications. However, there is one caveat to this. The yield of transbronchial is around 30%. Cryobiopsy is closer to 80%, and open lung is closer to 95%. Cryobiopsy appears to have the lowest significant procedural complication rate with the greater yield and potentially maybe a sweet spot in tissue diagnosis. Now, it's important always to note there is a small percent of ILD that may not have a diagnosis despite tissue, and this should usually be seen and addressed on a case-by-case basis. And just a little bit small point on cryobiopsies. Oops, my apologies. It's actually coming to CMJAH quite soon. Our first list is actually next week, and we're hoping to get some tissue diagnosis for some challenging patients we have in the department. Therapeutics. Like I mentioned, ILD is diverse. So too are their therapies. And this is usually a separate discussion altogether, but let's focus on some general principles. And the general principles, like all theories in medicine, are broken down into supportive and specific modalities. I always want to start off by please counsel patients appropriately. Certain ILDs carry a 5-year survival of less than 50%. So having ILD as a complication or a primary disease is an independent marker, so patients should be counseled appropriately on how significant this burden of disease is. Generally, when the etiology is known, treat the underlying etiology. If the etiology is unknown, treat the underlying disease process. When there is an exposure, try and withdraw it if identified. And also understand the concept of PPF, which It's actually well described in the ERS, or European Respiratory Society. And basically, it implies ILD with radiological signs and evidence of progression over time. Generally, these patients have progressive disease in the form of worsening symptoms, worsening images, and more than likely worsening pulmonary function parameters. And big classes that might have PPF is our idiopathic interstitial pneumonias, but quite a lot of other ILDs, including connective tissue disease, fibrotic forms of HP, fibrotic forms of sarcoid, and even certain drug-induced ILDs may progress despite withdrawal. Never forget, diseases are not managed in isolation. I did touch on this earlier, but I like talking about the multidisciplinary team. And is there evidence for the multidisciplinary team? There most definitely is. Over 17 studies evaluating the role of MDT. The outcomes were markedly diverse in these studies, but in general, involving other members of society leads to early therapeutic change, diagnostic changes, and improved therapeutics. That's important because different diagnoses carry different therapeutics and different prognosis. This is just a nice diagram of the role of the MDT, and it includes a whole holistic care, including the presence of physio, clinical nurses, radiology, pathology, rheumatology, and this is quite an important role in the evaluation of these complicated patients. Just some supportive therapies, not to be forgotten. Obviously, I did mention exposure withdrawal. Some centers actually use the role of an occupational medicine expert and an environmental hygienist who actually trained in detecting antigens that may precipitate a disease like hypersensitive pneumonitis. It's also important to diagnose and appropriately manage comorbidities. I did touch on earlier to address your traditional atherosclerotic risk factors, address your drug-induced side effects, and also importantly, there's a strong role of gastroesophageal reflux disease in IPF. They generally are asymptomatic, but there's a whole host of studies that show the role of providing a PPI appears to be minimal. However, the role of a PPI in scleroderma actually appears to be more better defined. Other supportive therapies. So pulmonary rehabilitation, quite emerging in the last 5 years. A lot of our supportive therapies are well studied in COPD, less studied in ILD. There is some emerging benefit. However, the benefit is like that in COPD. Probably not a big change on motility or morbidity, not a change on pulmonary function test parameters, but using the St. George's Respiratory Questionnaire, there was some improvement of quality of life outcomes. In terms of long-term oxygen, very similar principles here, no good survival data. However, there is a paucity of quality and quantity of evidence, and based on the recommendation in the ERS, where we can see these recommendations when to give oxygen, if you look at the bottom, it's a strong recommendation, but very low quality evidence available to support these statements. Also, it's important to note that these are a high-risk group of patients. They have low pulmonary function reserve, and they're prone to infections, with multiple guidelines actually advocating the use of our vaccination protocols. And there is observations that it does decrease all-cause mortality, and obviously we all know it's not specific to ILD. In terms of specific therapies, like I mentioned, always tailored towards the underlying disorder. It's important to withdraw or treat the underlying etiology, be it an organic or inorganic agent or a drug. In terms of smoking, it's not good enough for a medical doctor to just tell a patient to stop. And there's a whole host of smoking cessation therapy and guidelines available, both with pharmacotherapy and non-pharmacotherapy available. And it's also important to know when and how to treat. We'll get into this a bit quite soon, actually. Again, an enormous topic to cover. In terms of key pointers to etiologies, corticosteroids actually remain the backbone in the majority of ILDs, but not all. This holds true in HP, drug-induced ILD, and smoking-induced ILD. Again, in connective tissue disease, quite a broad topic, but it's guided by a whole host of factors, including multi-system organ involvement, systemic clinical features. Again, the backbone of therapy actually does remain corticosteroids, but DMARDs and biologics being add-on therapy. It's important to look for PPF, which I touched on earlier, and when to escalate therapy based on clinical, radiological, and pulmonary function decline. We're all familiar with the common manifestations of lung involvements in connective tissue diseases. And there's some ACR criteria of when to give. I'm sure we're all seeing drugs we're all familiar with in the room, such as using MMF, azathioprine, even rituximab. There's some local data on that. And in general, there is some short-term glucocorticoid use in these patients. If I'm not mistaken, the recommendations are against glucocorticoids with scleroderma for its renal potential. In terms of specific therapies for sarcoid, it's important to know when to treat. There's been an area of debate in pulmonology for many years. Found an interesting algorithm in Nature, which basically said if there is progressive organ threatening with significant clinical impairment, that's when we consider oral corticosteroids. But in general, when steroids are required more than 6 months, please consider, do consider steroid-sparing agents. However, in general, oral corticosteroids do remain the foundation of therapy, again, in the majority, but not all, especially in IPF, which I will touch on now. It's important to note that always look for progression of disease and know when to escalate therapy. And don't forget the role of rare diseases like tuberous sclerosis and the role of mTOR everolimus in these patients. So the role of antifibrotics was actually bore on in IPF. Initially, IPF therapy was treated with corticosteroids, azathioprine, and acetylcysteine. And a Panther trial quite a few years ago basically elucidated that better therapy is needed in this disease. Then we had the emergence of nintedanib and pirfenidone. It developed actually in the late 90s, and they gained approval in the 2000s. The Tomorrow and Impulses trials supporting the use of nintedanib, and the Capacity and Ascent trials supporting the use of pirfenidone. Guidelines released in 2011, which recommended its use in IPF. However, we all know now that its role has widely expanded as this etiology of PPF, or this concept of PPF, has emerged. We'll start a bit with nintedanib. It's a small molecule, which by definition is actually less than 600 kilodaltons in molecule size. And like the name implies, it's a TKI. So it's a small molecule. It binds to a family of growth factor receptors. And simply put, it blocks fibroblastic proliferation. It's taken with meals, but any of us who've ever seen patients with this on this drug, there's a very high amount of GIT side effects, close to 70 to 90%, and it generally actually limits the use and requires dose reduction. It's also exceptionally expensive. Its use, however, has accelerated in recent times. The INPOL trial released a few years ago has actually been used for a whole host of fibrosing ILDs, and it showed some good parameters in attenuating decline in PFT parameters. There was some post-hoc analysis that it may improve survival in IPF, but its evidence in PPF for survival is still being studied. It also has an important role in usually second or third line non-small cell lung cancer, and there are some trials advocating its efficacy at 6 months. In terms of pirfenidone, it's a synthetic small molecule again. There's a complex mechanism of action. It's not fully defined, but it also attenuates fibroblastic activity, predominantly transforming growth factor beta-1. Again, there's a significant amount of GIT side effects and photosensitivity. Photosensitivity side effects were more described in the studies. A lot of these studies had predominantly Caucasian patients, just important to note for our local setting. Again, it's well studied in ILD, particularly IPF, but there is less evidence in PPF compared to nintedanib. Interestingly enough, some centers have tried combination therapy, but the benefit was not well established, with cost and side effects limiting its use. The last point I didn't include is which one is better. A lot of studies actually studying this, but it's usually doing post-hoc analysis. Some trials suggested there was no difference. Some trials suggested nintedanib had a slightly decreased FVC decline at a year compared to pirfenidone. So other modalities and beyond. Now we're going on to the last few slides. Lung transplantation. It's a well-documented life-extending treatment for patients with advanced disease. In all transplantation, it's important to know when to refer and when to list. There's numerous contraindications for lung transplant, specified selection criteria, and it requires dedicated expertise at dedicated centers and dedicated follow-up due to the wide amount of variations and complications which can be seen. Just important to know when to refer and when to list. Generally, patients with poor markers at onset should be referred immediately. And most transplant centers are actually ILD expert centers, as they are familiar with both therapeutics as well. And there's also designated time when to list the patients. So what does the future hold? A lot. In keeping with medicine as a whole, we are now trending towards targeted, directed, and personalized medicine. Obviously, this makes sense given the role of the telomere and other complex genetic polymorphisms involved and coming out in terms of ILD. And the advancement actually starts from diagnostics to therapeutics. There's some actually, interestingly, in the journal CHEST, some specific digital imaging, which actually are used in diagnostics and actually AI-based. And there's testing of this new circulating cell-free DNA, which may actually provide some prognostic benefits. It's also important to characterize the telomere length with fluorescence in situ hybridization. And this can be useful with generally patients with shorter telomeres, actually susceptible to short telomere syndrome, and may have IPF with our familial forms, especially now in TERK and TERT genes. And it's important that novel therapies are emerging as we develop more underlying understanding of our pathways and cellular profiles. So the other important thing is also a role of pulmonary vasodilators. Actually studied epiprostolol in IPF patients. The benefits were seen with quality of life and 6-minute walk tests. It's important to note that these are phase 3 trials. There's also newer drugs, which have really cool names. The I-0455, which interestingly enough is a phosphodiesterase 4 inhibitor. Phosphodiesterase is very important to us in pulmonologists and all of us as doctors, as it mediates a lot of anti-inflammatory effects via its effects on CAM. And then there's other cool drugs and other quite popular drugs which are being either repurposed or novel drugs created that may emerge in the future. Thus, exciting times in the world of ILD. Oops. And thank you. It's an honor presenting at the forum. I'd just like to acknowledge my chair, the hospital, its staff, and the Wits Department of Internal Medicine and Pulmonology. Thank you.